brings about differentiation of the cell type from one form to another form, which is capable of handling the stress. And the example we gave was Barrett esophagus. In someone that is having reflux esophagitis, when there is reflux of gastric acid from the stomach to the esophagus. So the esophagus, we want to differentiate into the epithelial cells of the stomach to be able to handle that reflux. So it changes from stratified squamous to simple columnar. That is a metaplastic change. Another one is smoking. An individual that is smoking is exposed to irritants from the smoke, which forces the differentiation of the respiratory epithelium, which is pseudostratified squamous, to simple to stratified squamous rather. Sorry about that, guys. That's a mistake. It changes the epithelium of the respiratory tract from pseudostratified squamous, pseudostratified columnar rather, pseudostratified columnar to stratified squamous. So the stratified squamous is capable of handling the the smoke irritant. So the stratified squamous can further now progress to dysplasia and eventually stratified squamous carcinoma, squamous cell carcinoma, when the irritant persists and is not stopped. So we talked about hyperplasia and metaplasia to be background lesions that can develop into dysplasia. So as I said, dysplasia just means disordered precancerous epithelial cell growth. So when the epithelial cell growth is becoming disordered and we are seeing some particular pattern of changes, we know that okay, this cell is undergoing dysplasia and there's a potential that it's going to end up to be malignant. So what are these plastic changes we talked about? We said we are going to look at the entire cell and we are going to look at the nucleus. So for the entire cell, we are looking at the uniformity of the shape and the size. So there's going to be loss of uniformity of the shape and the size, which brings about scattering of the tissue orientation. So destruction of the loss of uniformity of the cell shape and the cell size is what we call pleomorphism. This will culminate in loss of the tissue orientation. Then we look at the nucleus. We are going to notice that the nuclear cytoplasmic ratio is going to be increased and there's going to be chromatin clumping. This can progress to cancer of any type. So someone that has Barrett esophagus is going to differentiate into adenocarcinoma. Someone that has uh, um, stratified squamous epithelium change due to smoking, that person can develop a squamous cell carcinoma. We said dysplasia occurs in grades, in stages 1 to 3, mild, moderate, severe, depending on the level of affectation of the epithelial cell. So if the topmost cells are affected only, that's mild. If it gets to the middle layer, moderate. If it gets to the layers that are most basal, that's severe. And severe dysplasia is also known as carcinoma in situ, and it is not reversible. The mild and the moderate are reversible. We talked about cellular injury to be reversible or irreversible. So after adaptation, if the insult still persists, what will happen to the cell? They will get injured. So it can progress from reversible injury to irreversible injury. So irreversible injury is like eventual death of the cell. So what happens in reversible injury? We said most of the insult will cause affectation of the mitochondria and there's a drop in the level of ATP. ATP drop affects the activity of the sodium potassium pump, which is responsible for pumping out sodium to the exterior and pumping in potassium from the exterior into the interior. So if that pump cannot function because it is ATP dependent, there's no way they can move sodium from the interior to the exterior. So sodium persists in the interior. It is osmotically active. Water follows it. There is cellular swelling. So all the cellular organelles swells. The cytosol swells, the mitochondrion swells, the endoplasmic reticulum swells, the Golgi body swells, and there's going to be disturbance of the function of these guys. So what happens next after the cellular swelling? We talked about the the cell membrane bulging out to form blebs. So they are filled with water too, kind of, and they form blebs. It's going to cause swelling of the rough endoplasmic reticulum, which will lead to detachment of the ribosomes from it, and that will bring down protein synthesis because of the fact that the cells are going to adopt the anaerobic pathway to generate energy. That will bring about lactic acidosis. That will generate all this acid that causes nuclear clumping. So after the hydropic swelling, there is blebbing of the membrane. There's detachment of ribosomes from the rough endoplasmic reticulum. There's no protein synthesis again. The acid causes clumping of the chromatin. Overall, there is loss of function of the cell, and we can have myelin figures to which we talked about to be formed due to exposure of the cell membrane to free radicals. So they get peroxidized. Then it can progress to irreversible form. So in irreversible form, instead of us just having detachment and there's destruction. There's destruction of almost everything in irreversible. So the membrane that is forming bleb gets destroyed. And when it gets destroyed, we are going to have leakage of cellular content to the extracellular space. So if you are looking at myocardial cell out now, troponin will find its way out. And that could be a marker that we can detect clinically. No, not clinical, no, laboratory. So the process of laboratory test to diagnose any disease that related to myocardial cell death, like myocardial infarction. Because when there's irreversible injury to a myocardial cell, there's damage to the cell membrane, troponin escape into the blood, and we can detect it. So when the cellular enzymes and all those things escape, there are some things that will also come in, like calcium, because calcium is always waiting at the door to enter because it is extracellular. So it's always waiting to find a way to enter into the intracellular space. When it gets in, it activates the degradative enzymes that we talked about. So that is the enzymes that will now finish up the process of destroying the cell. What are the enzymes that this calcium will activate? The protease enzymes and the phospholipase. So phospholipase will take out all the lipids in the cell, while the protease will take out all the cytoskeletal structures and all the proteinous structure within the cell. The mitochondrion too, they are going to be destroyed. There's going to be interruption of the electron transport chain. ATP synthesis is halted. There's destruction of the lysosomes. Those guys are rich in hydrolytic enzymes. The cell itself is exposed to those hydrolytic enzymes, and there's eventual self-destruction. There's autolysis. The nucleus undergoes some specific changes that occurs in stages. Echinosis, which is condensation of the nucleus. So once we are seeing all these nuclear change, not chromatin clump. So once we are saying that it's undergoing echinosis, karexis, we know that it's either this cell is undergoing apoptosis or it's undergoing necrosis or irreversible cell injury. So for the nuclear change, we talked about pykinosis, which is condensation of the nucleus. Condensation. We talked about karexis, which is nuclear fragmentation due to endonuclease cleavage of the chromatin. So they become fragmented in the entire cytoplasm. Then the last one is now eventual disappearance of the cell, which is cryolysis. We don't see it anymore. And there are some amorphous densities or inclusion that can be formed in the mitochondria before it eventually disappears, which are just fraction of the membrane of the mitochondrion attaching to calcium. So they form the calcium that has entered. So they attach to the phospholipids from the mitochondrial membrane, and they deposit within the mitochondrion as amorphous density. So I feel once we are seeing that the membrane is compromised, we already know that something severe is happening. We are seeing blebbing that can occur in maybe apoptosis or reversible cell injury. So what are the mechanisms by which the cell can die? We've talked about necrosis as irreversible cell injury. Another one is apoptosis. We said this one is typically the major route for um, taking out cells that are programmed to die, cells that we know that they are going to die when they get to some particular time or period. And we said, in addition to that, it's also responsible for taking out cells that have their DNA compromised, either by insult from radiation exposure, from infection, from toxins, or any cell that has accumulated misfolded protein in it, or any cell that has also suffered hypoxic insult. So those three things are very important. So DNA damage either from radiation, from maybe radiotherapy, toxin, from maybe toxin, maybe aflatoxin or anything from any source, or um, infection, maybe hepatitis B causing DNA damage or anything, you know, those guys can trigger the killing of those cells infected by apoptosis. And we also said, okay, in addition to DNA damage, cells that have in them misfolded protein. Example of that is amyloidosis. An example of a misfolded protein is amyloidosis. So any cell that have amyloidotic accumulation, they can die by apoptosis. They are typically taken off by apoptosis. That's why apoptosis, amyloidosis is actually bad for the cell because it can trigger cell death through this pathway. We also talked about apoptosis occurring in normal embryogenesis, which is one of the cell program, cell death pathway, tissue remodeling in embryogenesis, when a regulatory factor is withdrawn, and the other ones I've talked about. We also said it's involved in negative selection in the thymic medulla, and we said it's also involved in mediating cell death from exposure to cytotoxic T cell and natural killer cell. So, what are the specific pathways? Intrinsic, the extrinsic, and the perforating granzyme B. So, all those ones of the embryogenesis, removal of the growth factors, those intrinsic mechanisms that is applicable to the body itself. The embryogenesis occurring in the body is an intrinsic process. Down regulation of a regulatory factor that stimulates growth is an intrinsic process. Exposure of the DNA to radiation is an intrinsic process. Accumulation of misfolded protein, hypoxia, they are intrinsic process. So all these ones will trigger intrinsic pathway. And what they will do is to activate P53 that will activate the bad genes. What are the bad genes that promote apoptosis? The BAC and the BACs. So what would these guys do? They are going to make pores within the mitochondrial membrane that is going to provide an escape route for cytochrome C to find its way into the cytoplasm. And we said when cytochrome C gets into the cytoplasm, it binds to ATP. That is why apoptosis is ATP dependent. We must always remember that apoptosis is ATP dependent. It's an orderly process. So they want to make sure that they are doing everything in the right manner to avoid inflammation. They don't want the membrane to be compromised. They want to do it, and that process is going to involve energy. So the caspase binds to ATP and it becomes activated. I'm sorry, the cytochrome C binds to ATP, it becomes activated, then it binds to and activate caspase. So caspase is the cytosolic protease that will now start doing the cleaving it wants to do. So what are these cleaving stuff that the caspase will do? Number one, it will cause degradation of the cytoskeleton within the cell. That cytoskeletal dispersion is going to make the cell shrink. So you must always remember that when the cytoskeleton is degraded, it's a protease. It destroys, the protein framework of the cell. They reduce in size. Then, because of the fact that the protein framework of the cell membrane is destroyed, they are going to form some invagination, some blebs, and those blebs are just containing fragments of the cell in bits. So if you're forming those blebs, small bleb that is containing some organelles, it will take it out, target it to macrophagic invasion and damage. So it forms a bleb from a portion of the cell that is containing some few organelles. If you take it to the macrophage will eat them, and nothing is, triggering inflammation. There is no activation of any inflammatory process. They are being taken out like that until there's eventual dissolution of the entire cell. So in addition to cytoskeletal dispersion, reducing the protein, causing shrinking of the cell, that cytoskeletal dispersion is responsible for forming the cytoplasmic bleb. Then the caspase is also going to trigger some nuclear changes. But here we are only going to talk about pekinosis and cryoexis. So the chromatin within the cell is just only going to condense, and that is why it is going to stay basophilic. We said Na RNA and DNA within the cell are basophilic, distinct basophilic. Why the fact that there is a um, degradation of the proteins within the cytosol by the caspase. The RNA is within the cytosol. You don't find DNA. DNA is in the nucleus. So RNA, some RNA fragments are within the cytosol. So they are going to be taken out. And RNA, like DNA, stains basophilic. So if RNA is no longer there, the cytoplasm will stain eosinophilic. So in an apoptotic cell, the nucleus stains basophilic due to condensation of the chromatin, while the cytoplasm stains eosinophilic. So in addition to pykinosis, which is a determining, guys, I forgot to mention that pykinosis is the most important characteristic feature of a cell that is undergoing apoptosis. Pykinosis, very important. Yeah. So after the pykinosis, the cell stuff progress to cryoexit. So cryoexit is just when you have fragmentation of the chromatin, and that is all. So after all those cells are formed, you form the cytoplasmic bleb that is containing some portion of the organelles, and they move out to the macrophage for degradation. So we talked about the relevance of the backs and the back, which is important for the intrinsic pathway. And we said there are some BCL2, BCLXL that are working against the back and the back. So these ones are trying to protect this membrane of the mitochondrion so that it doesn't get compromised and there's no leakage of those cytochrome C. And they are anti-apoptotic in the process because they won't trigger apoptosis if you can't leak out cytochrome C. So that is why someone that has a chromosomal arrangement of chromosome 14 and 8 in follicular lymphoma can develop malignancy because this happens in B cells. The B cells have this transfer, this chromosomal translocation. The chromosome 18 aspect of it codes for the BCL2. The 14 aspect is coding for a portion of the immunoglobulin that the B cells produce. So once that translocation happens, immediately the B cell expression is going to be constitutive. It just keep expressing. Its production is very high. So that means that that cell will not die because caspase will no longer be activated and it will, develop into a malignancy. That is, or a tumor, a tumor rather. So that's the basis for follicular lymphoma. They don't die because of the fact that they have overexpression of BCL2, which is an anti-apoptotic factor. Looking at the death receptor pathway, death receptor pathway, we are just looking at some receptor interaction. TNF alpha ligand and FAS ligand interaction, which are predominantly located on the cytotoxic T cell, as well as TNF alpha receptor and FAS on the cells that want to label to die. So, for example, the TNF alpha ligand and the TNF receptor interaction is mediated in killing of cancerous cells. So the TNF alpha is released from the cytotoxic T cell, while the TNF alpha receptor is already on the cancer cell. They just bind together. Once that interaction happens, that complex is going to activate the caspase directly, and the caspase will now cause the cytoskeletal dispersion and all those things that we have talked about, which is the final common pathway. The FAS FAL interaction is important in negative selection in the thymic medulla. That's the way we can eliminate self-reacting T lymphocytes. If that interaction doesn't occur, we are going to have persistence of many self-reacting lymphocytes, which proliferate and accumulate in so many lymphoid organs, including the lymph nodes, the spleen, the liver, causing lymphadenopathy, causing splenomegaly, causing hepatomegaly, and that is what we call the autoimmune lymphoproliferative syndrome. In addition to that, because they can recognize self-reacting lymphocytes, they can recognize self-antigen, because normally they should have been eliminated through the fast ligand interaction. But because that interaction doesn't happen, there's a problem with the fast component of the receptor coupling. So that interaction doesn't happen. There's no way you can eliminate those self-reacting lymphocytes. They attack self-antigens, particularly in the bone marrow, destroying the red blood cell, destroying the white blood cell, destroying the platelet, causing autoimmune cytopenia. So once you remember lymphadenopathy, splenomegaly, and autoimmune cytopenia, you know that is likely to be autoimmune lymphoproliferative syndrome, which is due to defective fast ligand interaction. Then the last pathway is the perforin granzyme B pathway. Perforin granzyme B pathway is mediated, or it is utilized majorly by the cytotoxic T cells and the natural killer cells to take care of their own cells that they want to kill off, which could be viral infected cells or cells that have um, uh, cancerous cells or tumor cells. So how do they work? Once there is the fast interaction, you know, um, the thing is this the cytotoxic T cell can bind to any cell it wants to destroy via the fast ligand, and it can kill off that cell through the fast interaction. But in addition to that, it can also use this perforin granzyme pathway. So when there is attachment of the cytotoxic T cell to the cell that it wants to kill off, it's going to release the perforin. So perforin will make a hole in the cell that it wants to kill, and granzyme will follow that hole, and the granzyme B will now activate the caspase that will now trigger the process of the apoptosis. So that is all. So today we will now be talking about the process of necrosis. So necrosis, we have talked about it as irreversible cellular injury, and we have said that in irreversible cellular injury, there's a compromise of the plasma membrane. So the plasma membrane gets damaged, unlike in apoptosis that the plasma membrane is intact. Here, the plasma membrane is not intact. They have been damaged. Cytosolic components have escaped into the exterior. When the cytosolic component escapes into the interior, calcium also will move in to the interior. And when calcium moves in, what does it do? It activates some enzymes, some degradative enzymes, like phospholipase and protease that will eventually lead to entire dissolution of the cell. So those enzymes, they are going to degrade the cell and bring it down. But in some situation, that might not happen. Please, in some situation of necrosis, that might not happen. The enzymes might not be able to degrade the cell because they are denatured. This is not a general phenomenon. It is only in coagulative necrosis that the enzymes that are entering are not able to degrade because they are denatured. So one thing is, if someone has suffered ischemic insult, there's no blood flow. That ischemic situation is going to make the proteins in the entire cell to be inactive. They are denatured, so they cannot work. So that's why you cannot degrade the cell in coagulative necrosis. So we'll get there. But the normal thing is that, okay, once there's a compromise of the cell membrane and the calcium comes in and activates the protease enzymes as well as the phospholipase in the cell, there's a damage to the cell. You dissolve the cell, you lose the entire cellular architecture, you bring it down. But in some situation, you might not be able to break down the cell because the enzymes, the protein that are supposed to do that process, they are denatured due to ischemia. But generally, in necrosis, there's intracellular complement leak. So when that leakage occurs, a local inflammatory process follows, and you don't have inflammatory reaction in necrosis. In apoptosis, you only have that in necrosis. Now let's look at the different histologic and morphologic form of necrosis. So we have about um 7 of them. Okay, 6 of them rather. So 6 of them. So let's start with the first one, coagulative necrosis. The major insult, the major insult for coagulative necrosis is someone that had suffered ischemia. Ischemia. So there's reduced blood flow to the solid organs in the body for whatever reason. Maybe there's atherosclerotic occlusion, or there is a ruptured plaque, or there's something happening, occluding the lumen, and blood cannot get to those solid organs. The type of cell that they are going to experience will be the coagulative one. So we are going to see coagulative necrosis. What is the peculiarity of this coagulative necrosis? Yes, the cells are going to get injured irreversibly. There's going to be compromise of the membrane, just like we talked about. Calcium is going to come in to try to activate the enzymes that are in the cell. But because of this hypoxia from the ischemia. Because of the ischemia, those enzymes, they are already denatured. They cannot work. So proteolysis is blocked. Proteolysis is blocked. So that means that in a cell that is undergoing coagulative necrosis, the entire cellular architecture is preserved. You are destroying the membrane, fine, but the entire cell, the organelles, everything are still intact there. So once you see it under microscope, you notice that okay, this cell, this architecture is still there. This is likely to be coagulative necrosis. Please, once you see that in the question, that they are talking about, necrotic process, and they are now saying the tissue architecture, the cell architecture is preserved, you know that they are talking about coagulative necrosis. But one thing I want us to pay attention to is that in coagulative necrosis, it is only the nucleus that will disappear. That was why I was trying to mention it initially, that out of all this process that happens in irreversible injury, it is only the nuclear degradation that happens independent of all these enzymes from the calcium. It doesn't depend on that enzymatic um, um, action for its own process. Each will happen independent of those enzymes. So the cell is going to undergo pykinosis, cryoexis, and eventual dissolution, and the nucleus disappears. Another clincher for coagulative necrosis is eosinophilia. So there's increased eosinophil stain uptake by that cell. Why? Because that cell is having a lot of denatured protein. Denatured protein stains eosinophilic. So there's a kind of explanation for that. So they were just talking about exposure of the hydrophobic compartment of the cells, then which interact with the hydrophobic compartment of the eosinophil. Yeah, that's a long story. We don't need to memorize that. We should just know that if a cell has experienced coagulative necrosis, the denaturization of those proteins will make them eosinophilic. And when you stain that cell, it will stain eosinophilic. You can use that one to remember it, or you can use the fact that the nucleus has disappeared. And we said nucleus normally should stain basophilic. So if the nucleus is not there, there's nothing to take that basophilic component of the H and E dye. So that means that it is only the eosinophilic part that will be taken, and there's going to be cellular eosinophilia. Before we move, coagulative necrosis is the only form of necrosis that happens in following ischemic insult to all the solid organs in the body except the brain. Please, that is very important to remember. It is only the brain that will not undergo coagulative necrosis following ischemia. So if there is someone that has a stroke, there's an occlusion of a major artery in the brain, and that brain tissue is suffering ischemic insult, which will eventually lead to an infarct from necrosis. They don't die through the coagulative necrosis process. No, it takes another way. It dies through another form, which we call the liquefative necrosis pathway. We'll talk more about that. So that is all about coagulative necrosis, and this is how the cell will look like. We can see this slide A. We can say that this slide is what can we say about it? Anybody?
Eosinophilic. The
Exactly,
red.
exactly. Thank you. You can say that it's red. That is it. So it entirely eosinophilic. You know that is what you find in coagulative necrosis. So the next one is liquefative necrosis. So in this one, this is just talking about any process that degrades the solid tissue into a liquefied viscous mass or structure. So we are breaking down and dissolving the solid tissue. You know that in coagulative necrosis, we are preserving the cell architecture. Now, before I move from that coagulative necrosis, let me say to us that they will eventually break down that cell, but it is not from the denatured protein in the cell. It is actually due to the neutrophils, the white blood cells that comes around in response to the inflammatory. You guys remember that the membrane is compromised. Cellular content has leaked out. They have attracted the white blood cell. The lysosomal enzymes of the white blood cells are still active. They are not denatured because they are not the one that is suffering the ischemia. So they will now be the one to later bring down the cell later. That will be later. That will be a later event. But primarily, initially, what we see is preservation of the cellular structure, dissolution of the nucleus, and relative eosinophilia compared to the other components. So in liquefactive necrosis, it happens when there's a CNS infarct. So when there is hypoperfusion of the CNS, the brain, instead of having coagulative, it is liquefative. Or you can see it following bacterial infection or fungal infection, because those ones will release enzyme that will degrade the tissue and make it liquefied. Now, let's take the process one by one. So, if somebody suffers a bacterial infection and then the bacterial cells invade that particular tissue, the next thing is the white blood cell come around, inflammation. They want to come and arrest that bacteria. So, the first cell that's going to respond to an infection will be the neutrophils. They are the acute inflammatory cells. Within like 1 to 3 days, they are there. And neutrophils contain lysosomal enzymes. So the lysosomal enzymes are there to degrade the bacteria, but in the process, it can degrade some part of the neighboring tissues. So they degrade the neighboring tissues too, and they liquefy them. That's what those hydrolytic lysosomal enzymes do. They digest those solid tissue that they are invading, and they liquefy them. So you are going to have later you are going to have a space, a cavity that is containing living and dead neutrophils and the cellular debris, that is the tissue that you have degraded, as well as the dead microbes. So the cellular debris contains the living neutrophils, the dead neutrophils, the necrotic tissue that you have degraded. The necrotic tissue that we have degraded, the living white blood cells. Those are, and also, yeah, so we mentioned that all those ones will exist within that focus of inflammation. There might be walling off of that area because the nearby LD tissue will not want the inflammatory process to get to them. So what we will do is that they will just start proliferating their capillary. So that capillary proliferation is going to form a wall around that area. So there's going to be a wall formation due to proliferation of the capillaries, due to proliferation of the fibroblasts, and they are going to encave, they are going to enclose those focus of infection. So there you are going to have liquefied matter that is containing the dead white blood cells, some of the living white blood cells, as well as the necrotic tissue and the bacteria that have been digested. So you call that abscesses. So it might not be bacteria only. Fungi too can form abscesses like that. But later, just know that after the cells have been degraded, they are going to form, this cystic space because of walling off from surrounding tissues due to capillary proliferation, fibroblastic proliferation. In CNS, in fact, there is liquefaction of the solid tissue of the brain. But what is causing that is due to the fact that the brain is very poor in connective tissue. The brain doesn't contain solid connective tissue like muscle or anything. No. The brain is entirely made up of lipids and enzymes. And the brain has a lot of hydrolytic enzymes. They are there. They are very abundant within the microglia of the brain. So the first thing that happens when there is ischemia, and that ischemia becomes prolonged, and the cells are, dying, the macrophage will be the one to respond to that. So the neutrophils, the macrophage, they come in. The macrophage of the brain are called the microglia. Those guys are rich in hydrolytic enzymes. They release the hydrolytic enzyme and they start degrading the neurons. They start degrading the neurons. So they will liquefy the neural tissue and they are going to form exactly what we have talked about initially. So it's going to form a cystic focus that is containing dead neutrophils, dead macrophages, liquefied neural tissue existing within a cystic space, and later they will become enlarged to form cavities. That is it. So what is mediating that liquefative necrosis is the enzymes that are actually digesting. In coagulative necrosis, the enzyme cannot digest the cell because they are denatured. But in liquefative necrosis, the enzymes are capable of digesting. So the brain enzyme doesn't respond to that hypoxic or ischemic insult and they get denatured. No, because they are too abundant. They are very much. They will still degrade the neuron and you have liquefative necrosis. So in the early stage, you are going to see the macrophages or the neutrophils coming around. For example, when we're talking about bacteria is strictly neutrophils in the early stage. But for the brain, we are going to see both the neutrophils, the macrophage coming around, degrading, digesting the tissue. So we are going to see the cellular debris, which is the digested products, and the white blood cells. Then later, they start forming the walling off, which brings about the appearance of the cystic spaces and the cavitation. Once you see this in a description, in a question, you know that they are talking about liquefactive necrosis. And don't forget, it occurs in abscesses and in CNS infarct. It means that if somebody has a renal infarct, that's going to be coagulative necrosis. Splenic infarct, coagulative. Pulmonary infarct, coagulative. Um, Hepatic infarct, coagulative. But brain infarct is liquefactive. Hydrolytic enzymes are abundant in the brain that can digest the brain tissue. Brain bacterial infection, fungal infection, which develop into abscesses, liquefactive necrosis. Another type of necrosis occurs in what we call caseous necrosis. So this is kind of necrotic pattern that we see in some particular infection. The way I just look at, okay, so this is a picture showing area of infarct in the brain. We can appreciate this, okay, and this is the caseous necrosis we are about to talk. Well, we are about to discuss now. So this is you can see this whitish material. It looks like cheese. For some of us that are Yoruba, it looks like wara. I know that some of us are even familiar with wara and we are not Yoruba. So you know that wara looks whitish, cheese, whitish. So that's how the name was derived. Caseous necrosis. Now, caseous necrosis is like a kind of necrotic pattern that is seen in granulomatous lesion. And granulomatous lesions are typically found in, although not only confined to infection, but most of the time you see it in infection that is very, very chronic and difficult to degrade. So if you have infection from a microorganism that is very virulent, it can evade immune response, either by protecting itself or by just escaping. You know, the only way the body can take care of that is to confine it within a granuloma. Since they cannot degrade it, it will just, wall it off within that granuloma. And some of them even instigate the formation of the granuloma so that they can shield themselves from the immune system, like tuberculosis. So that granuloma formation is very common in tuberculosis, in systemic fungal infection like Histoplasma capsulatum, in some organisms like nocardia, syphilis, leprosy. We are going to talk about them as we move, but we should just know a few. And I don't think they can go beyond TB or fungi. So let's just stick with that. As we are learning, we are going to the systems, we'll be getting exposed to organisms that forms the granulomatous inflammation. We don't need to know all of them now. Just know that tuberculosis infection, Histoplasma capsulatum infection, which is a fungi, they can trigger formation of granuloma. And we have talked about granuloma formation during the course of our immunology discussion. So we said granuloma is just like a complex, you know, that is shared with the macrophage, taking that organism first. So if TB comes in now, histoplasma comes in now, it is a macrophage that will respond to them first, you know, because macrophage are also antigen presenting cells. They mob them, they bind to them, they embrace them, they now take them to the lymph node. That lymph node, see what I saw, guy. Lymph node will now start differentiating into TFR1 that can help to contain that infection. So there's release of interleukin 12. Interleukin 12 will activate the naive T cell to differentiate to the direction of the TFR1. So TFR1 are formed. TFR1 will quickly want to rescue. But before that, TFR1 will now release gamma interferon. That, okay, gamma interferon, go and activate more macrophage. We need more macrophages. So the macrophage are going to get activated with the gamma interferon. And the activated macrophages will now form TNF alpha. So the TNF alpha is going to cause epithelial differentiation of the macrophages. That is, the macrophages are going to fuse together to form giant cells that are called epithelial cells. They look like epithelial cells. They are joined together to form giant cells. Now, all these things will now form complex around that tuberculosis. So you guys can see the kind of army that is um, that is surrounding the tuberculosis infection or the histoplasma. In the innermost layer, you have the tuberculosis infection there. Next to it is a macrophage that is engulfing it. Next to that is the fused macrophages that we call the epithelial cells. Then at the outermost portion lies the T-helper cells, trying to contain that infection. But these infections are very stubborn that some of them will die, some of them will persist. So there's a complex that is formed by those that are dying and those that are still persisting that will call this caseous necrosis. So they are going to form amorphous densities, amorphous debris that are granular in appearance due to the fact that there are some cells that are dying and there are some that are not dying. So that's what we call the caseous necrosis. We are going to look at it. Grossly, we are going to see cheese-like appearance, which is represented by a focus of necrosis, containing dying cells and cells that are still living within a granuloma. We can see fragmented cells that have been killed up and debris surrounded by lymphocytes and the macrophages in the granuloma, having a cheese-like appearance. So once we see that description in a question, cheese-like appearance of an histology or something, containing both dead and living cells, we know that that is like surrounded by granuloma, surrounded by macrophages and lymphocytes. We know that they are talking about caseous necrosis because there's going to be a center of necrosis in that. Okay, we are seeing the gross image, we don't have the histology, but that's fine. The question will describe it. Once we see the question tilting towards tuberculosis, we know that it is caseous necrosis they are going to. This is not coagulative, this is not liquefactive. It is caseous necrosis because this is more serious than bacterial, just common bacterial infection like strep pneumo. Your neutrophils will not take care of your TB now. You need something stronger like macrophages, and in the process of surrounding the tuberculosis, they are going to kill off some of them, and they are going to form, a center area of caseous necrosis. The next form of necrosis is fat necrosis. Fat necrosis. This one is very easy, and they like testing this guy a lot. So we must pay attention to it. Fat necrosis can happen following two pathways: enzymatic one and the non-enzymatic. The commonest one is the enzymatic one. So what happens? It can happen in somebody that has acute pancreatitis, that's the enzymatic route, and in somebody that has suffered trauma to the breast, that is the non-enzymatic route. So what is a common pathway that is unifying these guys, this enzymatic and this non-enzymatic fat necrosis? There is degradation of the fat. That is a final common pathway. So we have the fat cells, which are known as the adipocytes, that contain fat. They store fat in there. If there's trauma to the adipocytes, or if there is, if okay, let me start with the trauma. If there's trauma to the adipocyte, they are going to break down those fats following the trauma. So the fat cells are going to break down into fatty acid and glycerol because fats contain triglycerides. So they are going to break down into fatty acid, free fatty acid, and glycerol. If it's due to acute pancreatitis, which is the enzymatic one, so somebody just developed acute pancreatitis, maybe the person is consuming a lot of alcohol, or the person is having gallstones, or he has gone through a procedure of ECRP or something, and there's damage to that pancreas, he's going to suffer inflammatory response, and there's going to be acute pancreatitis. So when acute pancreatitis happen, there's going to be elaboration of the pancreatic enzymes, particularly lipase and amylase. Those are the major pancreatic enzymes that are elevated threefold more than normal in acute pancreatitis: the lipase and the amylase. So what would the lipase enzyme do? The lipase enzyme, because of the fact that the pancreas is surrounded by area of mesenteric fat, the mesentery that surrounds the pancreas is very rich in fat. So those lipase enzymes are going to be secreted from the pancreas due to the inflammation, and they start degrading those metanectic fats. So the free fatty acids, that is liberated will now start surrounding the pancreas. So when the free fatty acids are released either from lipase digestion of the fat or traumatic attack to the fat in the breast, the free fatty acids that are liberated will bind to calcium. That's one thing about calcium. Calcium likes so many things. This calcium guy will bind to almost all necrotic tissue in the body. It will bind to free fatty acid that is roaming about. It likes it. It binds to necrotic matter, and it also binds to fat. So we are going to talk about the relevance of this later when we are talking about classification, dystrophic or metastatic classification. So calcium don't want to see all those free fatty acids lying around. It will just bind to them. It will bind to them. I'll call that process saponification because you form calcium soaps. Calcium complexing with fatty acid will form calcium soaps, which appear chalky white. And in addition to the fact that it appears chalky white, if you stain it with the H&E stain, they are going to be basophilic. They take up the blue stain. So if somebody has acute pancreatitis and you take a biopsy of the fascia that are surrounding that area, you are going to notice fatty necrosis because the lipase enzyme that is elaborated by the pancreatic tissue will start degrading the fat cells, making them necrotic, and they will release their fat. So their fat is going to split into fatty acid and glycerol. So the fatty acid component is going to chelate with calcium and to deposit on the pancreas, causing pancreatic calcification. The similar process also occurs in breast. So if somebody has trauma to the breast, that trauma is going to kill off the fat cells, the adipocytes. So they will die by necrosis, and they will also release their fat that they are storing. So the fat is going to be hydrolyzed into free fatty acid and glycerol. The glycerol component is going to bind to calcium and is going to deposit within those fatty cells that are necrotic. And once you stain those cells, you are going to see features of necrosis. In addition to that, you are now going to notice that they are basophilic because those calcium soap will pick up the basophilic component of the dye. Another one, so once we see pancreatitis, fat necrosis should be coming to our mind. Trauma to an area that is containing a lot of fat tissue like the breast, fat necrosis should come to our mind. And the fat necrosis one following breast trauma is non-enzymatic. The one following acute pancreatitis is enzymatic, requiring the lipase enzyme. The next one is fibrinous necrosis. Now, once you see fibrinous necrosis, this word fibrinous, two things should come to our mind. It can be immune or non-immune. So for the immune, it is due to deposition of immune complex in the vessel. That's where you see it. The cell that is undergoing the necrosis in the fibrinous necrosis is actually the vessel wall because of two reasons. Number one, for the non-immune one, it is due to the fact that there's an increased blood pressure that is causing, because if you guys remember the Virchow's triad, Virchow's triad is made up of stasis, turbulent flow, or endothelial damage. Abi guys.
Yeah. Yes.
So
Yes.
if there is turbulent flow from hypertension, the normal laminar flow of blood is kind of um disturbed. So the blood cells start moving in different direction and they start eating the endothelial cells. They are going to damage the endothelial cells, and you are going to have leakage of inflammatory cells into the tissue. So when inflammatory cells move into the tissue, they move into the vessel wall. You are going to have um, activation of the complement. All those things, they will trigger so many pathways. They will trigger coagulation cascade, and at the end of the day, we are going to have fibrin being deposited. You guys know that once you damage the endothelium, you are going to activate the clotting pathway. There's no way you can go about it. Am I wrong? Endothelial injury is one of the causes of the intrinsic pathway of coagulation. I hope you remember that from our hematology
Yes.
discussion. Hello?
Yes.
Yeah.
Yes. Dr.
So
Power.
somebody that is hypertensive have that damage to the endothelial cells due to the turbulent flow, and there's activation of the intrinsic pathway of coagulation. So you have clot formation and eventual fibrin deposition. So that fibrin will deposit within the vessel wall. That is one. That is for the non-immune. You think about hypertensive causes. For the immune one, it is due to deposition of immune complex from whatever source in the vessel wall. Those are the two things that will trigger the necrotic pathway within the vessel wall. So if you are thinking of polyarthritis nodosa here, so polyarthritis nodosa, the antibody antigen complex that is deposited is actually that of hepatitis B. That's why most situations of polyarthritis nodosa is actually with hepatitis B. So hepatitis B antigen, hepatitis C antibody, they are going to complex together and deposit within the vessel wall. That is what is mediating the changes in polyarthritis nodosa. It is reasonable to say that you will see fibrinous necrosis within the vessel wall in someone that has SLE, because SLE is associated with formation of immune complex. Someone that has rheumatoid arthritis, you will see fibrinous necrosis there via the immunologic route. But for the non-immune one, you are thinking of anything that can increase blood pressure. Hypertensive emergency, blood pressure is like 180, 120, and there's end organ damage. What's the end organ here? There's damage to the vessel wall, maybe leading to AKI or something. You know, you will see fibrinous necrosis because they will lead to formation. So all these immune complexes that are depositing within the wall, fibrin is going to attach to them because the immune complex is going to activate complement. Complement is going to activate the other inflammatory cells that will bring about activation of the coagulation cascade, and there will be deposition of fibrin. So this fibrin deposition must be there. That is what is giving them the appearance of this fibrinous necrosis. They are going to stain eosinophilic. The proteinaceous eosinophilic material that you are seeing is actually more of the fibrin. So we can see there's immune complex deposition, that's a type 3 hypersensitivity, or there is damage to the endothelial cell, there's leakage of plasma protein into that area, there's activation of the coagulation cascade with eventual deposition of fibrin into that vessel, which will lead to the fibrinous necrosis. And when you stain it, you are going to see eosinophilic layer of proteinaceous material. That is the fibrin that you are, particularly staining. So don't forget, immune complex as well as hypertension for many cause. Preeclampsia, there's hypertension through preeclampsia. Hypertension is a major thing in preeclampsia. So any hypertensive cause will bring about fibrinous necrosis. If you look at the vessels of somebody that is having hypertension, you notice this fibrinous necrosis changes in the vessel. And when a person is having all these changes, the person is at risk of developing complication because the vessel will start getting narrower, narrower. So the last one, this is the histology. Although this histology is not very clear, it's not very clear. It's not. This is not a very good image. This is the image for the fat necrosis. You can see all this fat, whitish stuff, and we can see the area, surrounding area of basophilic appearance. They are staining purple. That's where the calciums are deposited. So this white area are just fat cells that are still living, while the other ones have been, the calcium have deposited on them. The last one is gangrenous necrosis. Now, gangrenous necrosis is the same thing as coagulative necrosis. It's just a term that is used to change, you know, the definition of coagulative necrosis that is happening in some specific organs. Now, I want to expose us to the fact that gangrenous necrosis is not actually a laboratory diagnosis. It's not like all these fat necrosis that you see on histology or cases. No, gangrenous is not laboratory, it's clinical. Because what you see that will make you say that, okay, this cell that are here actually suffering gangrenous necrosis is when you see features of gangrene. You are seeing, like blackish discoloration of a particular tissue. And what are these tissues that we are talking about? The extremities, the digits, the hands, and the toes, as well as the GIT. We cannot say that the GIT, the intestine, is undergoing coagulative necrosis. I've not heard of it before. They will say the intestines are gangrenous. That's the term that they will say. The extremities, the toes are gangrenous. No, I've not heard of this saying that the kidneys is gangrenous. That even sounds very hard. They can suffer coagulative necrosis. You won't say they are gangrenous. So it is the same insult that is triggering coagulative necrosis that also brings about gangrenous necrosis. Maybe there is obstruction to blood flow, or maybe there's vasospasm from any cause that is reducing the delivery of blood to the intestine or reducing the delivery of blood to the extremity, the digit. We are going to say gangrene. Now, this gangrenous necrosis can be of two forms: wet and dry. The first one that happens is a dry ischemia. So you are just going to see that tissue appearing dark, firm, solid like this. It's going to be dry. That is due to the coagulative necrosis only. But this necrotic tissue is a nidus for bacteria to come in, especially putrefying bacteria like all these Clostridium perfringens. They like infecting necrotic tissue like that. So they are going to infect these already necrotic tissues. So a superimposed infection on a coagulative necrosis is what we call wet gangrene. So because this infection will now start putrefying this necrotic tissue, they'll start breaking down the lipid, the protein, forming fermentation products that's going to bring about swelling of this. So there are products that are going to cause swelling of this tissue. They are going to look swollen and they are going to be foul smelling. So once you see them looking molted, looking wet, looking edematous and foul smelling, you know that there's a superimposed bacterial infection. So that is a wet gangrene. So initially, when there's just ischemia only, there's no superimposed bacteria, it's just dry gangrene only. That was just due to ischemia, coagulative necrosis. But when you have a superimposed infection, that means you have a liquefactive um, necrosis superimposed on the coagulative necrosis because the bacteria will start liquefying those tissues. They'll start decomposing them. They'll start fermenting them. And the product will cause the edematous swelling of that tissue and it will be foul smelling. So that is wet gangrene. And the tissues that it typically occurs include those, it's just true, the extremities, the fingers, the toes, and the GI. Those are the regions where you can see necrosis.
Dr. Wale.
Yes, Dr. Precious.
So are you saying that in DM is not the infection that comes can we say this happens in DM here first of all?
In
The
the DM,
gangrenous necrosis.
yes,
Yeah.
the
So you
peripheral
mean that
arterial
it's the
disease.
ischemia that comes first?
You said, is it?
I always think is the what's it called? Is the bacterial infection that comes first before
No, no,
the
it's not the bacteria. It's not the bacteria. It's actually due to the occlusion first. It's the coagulation. That's the first thing. That peripheral arterial disease, from the DM, is going to reduce blood flow. So they have that first gangrene, coagulative necrosis. Is that when infection is now superimposed on it? It's very easy for bacterial infection to translocate to a necrotic tissue. They are devitalized. They don't contain oxygen again. And some of these bacteria that infect this tissue are anaerobic. That is why I mentioned um, Clostridium perfringens. It's one of those organisms that are anaerobic that likes necrotic tissue. They'll go to that area because there's already oxygen deprivation in that area due to the coagulation. Blood is not going there, oxygen is not there, and the cells are dead already. It's very
okay.
that's a fantastic area for it to thrive. Just get there and it causes the wet gangrene.
Okay. So
So
the ischemia first, then the organism finds a way.
exactly. So when the organism finds its way, you call that super infection or wet gangrene. So you can see
Okay.
liquefactive superimposed on coagulative necrosis.
Completely.
So let's look at these two questions.
Sorry, Dr. Babali.
Yes, Dr. Paulette.
Good morning.
Good morning, Dr. Paulette.
Please, this non-enzymatic fat necrosis,
Okay.
you said it occurs when there is trauma to the adipose tissue.
Yes.
So what breaks down the adipose tissue for calcium to bind?
It is a trauma. That
Okay,
trauma is what, so they don't require enzyme. There's already an insult. So that trauma is going to break them down. That is it. It's a trauma. It's not an enzyme. That's why
okay.
it is non-enzymatic. Do you get it,
Okay.
Dr. Paulette? You know that,
Yeah.
I don't know if you have seen, if you look at a picture of someone that has fat necrosis following trauma, you see that that breast will be deformed. It will look deformed. It's because of that breakdown of that fat cell by that trauma. It's just like you are eating something, it will degrade. That one is just there's no catch, there's no additional stuff, it's just the trauma directly. That one is very easy. So once the
Oh,
trauma
okay.
degrade the fat cell, they release the fatty acid, calcium comes in, you have your staining. So do you get it, Doctor?
Yes, I do.
All right. So let's look at the questions. Uh, Okay. A 65-year-old man comes to the emergency department due to acute onset severe right flank pain. There's nausea and there's vomiting for the past 1 hour. His medical conditions include prostate cancer and membranous nephropathy. The blood pressure is 148, 60 millimeter of mercury, and the pulse is 95. On physical examination, the patient appears to be in moderate distress due to pain and is diaphoretic. There's right costovertebral angle tenderness. Urinalysis shows hematuria. Contrast enhanced CT scan revealed a wedge-shaped perfusion defect, in the right kidney. The affected renal tissue is most likely to develop which of the following histology changes over the next several days. What is our diagnosis here?
Coagulative necrosis.
That is very straightforward. So why are you picking coagulative necrosis?
Because of the ischemia
Okay, ischemia to
to the vessel. I mean to the organ.
which
What
organ?
effusion defects in the right kidney?
Yeah, so what organ specifically?
The
Because it's
kidney.
relevant. Hello?
The kidney.
The kidney. No, don't think, I should not ask you. I should ask you because it's relevant. If we change this organ to the brain, we are not going to pick coagulative necrosis. Hope you know that. If there's a perfusion defect to the brain, which one are you going to pick?
Liquefactive.
The liquefactive. So it's important to identify the organ. You look at the organ. Okay, you are talking about perfusion. What is the organ? The kidney. What is the problem? Is it infection of the kidney? No, this is not infection. This is perfusion defect to the kidney. So this is likely to be a coagulative necrosis. So that is very straightforward.
Then is that wedge shape specific to coagulative?
Yeah, so it's just, it's not really specific to, it's just there's perfusion problem. Well-shaped infarct typically occur in uh how do I put it now? Uh should I say border should I say border areas of border zones of the body? But
Watershed.
it's watershed exactly. So watershed, that's what I want to say. But you know, but this one is not, I don't think it actually relates to anything. They're just trying to tell us the shape. I don't think it's something that is specific because you don't have watershed stuff in the kidney. You don't have it. But typically, when you see wedge shape, in fact, it's more likely to be at watershed areas of the body, like the brain. That's where you typically have this wedge shape pattern. So this one is just, the kind of shape that the infarct assumed. Do you get it, Dr. Lushola? It doesn't have any significant relevance.
Okay.
Yeah.
What out is the organ and then the fact that there was a perfusion issue.
The what?
So I'm wondering what gives it out as coagulative, the organ and then the fact that there was perfusion problem.
Yes, exactly.
All
The
right.
perfusion organ, the perfusion problem, and the organ. The fact that is, the kidney, and the fact that the problem is ischemia.
All right. Thank you.
Um. Okay. So this is another one. A 73-year-old man
Sorry,
comes.
Chief.
Okay, I'm listening.
Yeah, I understand the fact that the reasons why you mentioned it to be coagulative, but can it also be fibrinoid?
Okay, so why do you want to pick fibrinoid? Let me just see why. Why do you
It
think?
also involves the vessels, and for the fact that it's the patient has membranous, I think
Okay,
the kidney problem. Yeah.
so for you to pick fibrinoid, you have to see that it is the hypertension that is causing that damage. And if it's going to be hypertension, they will not tell us that there's a perfusion defect. So, do you get it, Dr. Paulette?
I'm getting it.
So, this one is talking about a perfusion defect. There's ischemia. It's different from the pathophysiology of fibrinoid. In fibrinoid, it can be to deposition of immune complex or hypertension damaging the endothelial capillary. And what you even have there is maybe extravasation of blood, like bleeding, into that compartment, causing fibrinous deposit. So, but once you see that what they are talking about is perfusion problem, it's not hypertension now. Perfusion, blood is not getting to it. You won't think about fibrinous. It will be coagulative.
Please,
Okay.
can I see the question one more time? Sorry.
So, perfusion defect. That's a clincher, Dr. Paulette. Perfusion defect. You don't have perfusion defect in fibrinous. It is hypertension that is damaging the cell wall there. The
Oh,
Okay.
vessel wall.
okay. Thank you.
Yeah, you're welcome. Are you okay, Dr. Lucia?
Yes, sir. Yes, sir.
Okay. So, we've taken that. Um, so let's talk about, you know, ischemia. So ischemia can happen before necrosis. And ischemia is just defined as um a condition where the blood supply or blood delivery to an organ does not meet the demand. You see, this ischemia thing is not necessarily talking about that blood is not moving. No. Blood might be moving. You might even have patency of the lumen and the person still has ischemia. That is why you need to understand ischemia to be an imbalance between demand and supply. Let's say that somebody has hypertensive heart disease. There's cardiac hypertrophy. It means that the muscles of the heart are now bigger. The oxygen that one will be consuming will be different from the oxygen that a normal cardiac muscle that is not hypertrophied will be consuming. That means that the demand of that heart has increased. The demand of that heart muscle has increased. In that situation, you need to increase the blood supply. If those coronary vessels do not dilate further to increase blood flow to that heart muscle, despite the fact that they are not occluded, that heart muscle can suffer ischemia. I don't know if what I just said makes sense to us. Hello, guys.
Please, can you repeat it?
Okay. So I said that ischemia is imbalance between demand of a tissue and the supply. That means that the supply is not commensurate with the demand. Is not equal to the demand. The supply is less than the demand. Now, I'm now giving us a situation that it might not necessarily mean that the vessel is occluded and blood is not flowing. I give an example of someone that have hypertension and the heart, you know, undergoes this hypertrophy. The heart muscle has enlarged because of the hypertension. That's a pathologic modification, a pathologic adaptation, hypertrophy. When it hypertrophies, the amount of oxygen that it will be consuming will be more than a normal heart muscle. Do you agree with me, Dr. Paulette? Or is it Dr. Princess now?
Yes, I
Yeah,
agree with you.
exactly. Now, in order to respond to that increased demand, what should happen is that the coronary vessels should dilate so that you can have increased blood flow to that muscle. If they don't dilate to increase that blood flow and they are not occluded, blood is still going, but they don't dilate to increase the blood flow. That heart muscle can still suffer ischemia because they have not met the demand of that muscle. It's still at baseline. They have to dilate so that they can increase the blood flow to the muscle. And if they don't do that, that means that the supply does not meet the demand and ischemia will happen. So that is that about the principle of ischemia. That is why somebody with hypertensive heart disease can suffer ischemia even without occlusion of the coronary artery. Because as the muscle is getting big and bigger, the demand is increasing. And it will get to a point that the coronary vessel cannot respond to that increase. They cannot dilate maximally again to respond to that demand. And that is when ischemia sets in. That is why ischemia sets in. So you must give the person drugs to help counter those remodeling that is happening in the heart. You don't want that hypertrophy to be happening again. You don't want it. That's when you now start giving your ACE inhibitor as well as your beta blockers that will help you take care of those hypertrophy because they are becoming maladaptive. You don't want them. Take it out. So because angiotensin enzyme is responsible in that remodeling, you give ACE inhibitor to inhibit that angiotensin. Sympathetic activity is involved in the remodeling. You give beta blocker to help you with the remodeling so that you can bring down the demand to what the coronary vessel can handle by reducing the hypertrophy. So what are the mechanisms of ischemia? The common ones: reduce arterial perfusion, maybe from atherosclerosis, reduce venous drainage. Of course, when there's venous drainage occlusion, it means that you cannot drain blood from that tissue. Blood will keep pooling in that tissue. There's going to be edematous swelling of that tissue. When there is edema of that tissue, the pressure there is going to rise and it's going to compress on the other vessels like the arteries and the capillaries. So there is no continuous inflow of blood to that tissue again because of that congestion. That's the concept of ischemia following venous drainage um, obstruction, you know. And that occurs in a situation of testicular torsion where you have twisting of the somatic cord. That means the testicular veins will be compressed and you have pooling of blood within the papilliform plexus of the testicles. So you are going to have testicular engorgement. The testicular engorgement is going to increase the pressure that will now compromise the arterial pressure. It will summon the arterial pressure to compress the arteries too. Arteries will not be able to deliver enough blood. And you guys will remember that even it's not even entirely about the blood, it's about the oxygen content. Because we can say that okay, maybe blood is still in the tissue now, maybe the veins are engorged and they are not draining. The blood there should be, but you remember that the blood there is deoxygenated. It's not useful to the tissue. It is the oxygen in the blood that we need. And the oxygen content of venous blood is very low. So it's useless. That's testicular torsion. But Chiari syndrome is occlusion of the hepatic vein. So the hepatic vein that is draining the liver is occluded by thrombus. That means that blood will not able to leave the liver. So that means that the liver will be congested. When the liver gets congested, it enlarges, there's hepatomegaly, there's compression of the hepatic portal vein and the hepatic artery that brings in blood into the liver. So when they become compressed, they can no longer bring in blood to the liver and there is ischemia. Shock. Shock is just anything that can reduce perfusion to the tissues, to the organs, and it can be, and in shock, majorly there is a reduction in the effective circulatory blood volume. That is, the blood that is within the intravascular compartment is reduced from anything, either by cardiogenic problem with the heart cannot pump, hypovolemic, the body is losing the blood to the exterior, maybe from bleeding, from anything. It can be distributive, they are pulling somewhere. It can be obstructive. So it can be pulling somewhere like someone that has anaphylactic shock, someone that has sepsis, they are pulling within the venous side, they are not moving out. Someone that has um what's it called now? What's the shock again? This obstructive shock. There's obstruction, usually at the right ventricle. They cannot get to the left side of the heart. Maybe someone that has a tension in pneumothorax, the pathophysiology is another thing entirely. We'll talk about it in respiratory, or someone that has a pulmonary embolism. If there's a pulmonary embolism, blood cannot move across the pulmonary artery through the pulmonary vein to get to the left side of the heart. So there will be shock. There will be shock. But there are some specific regions of the body that whenever this hypoperfusion happens, this ischemia or hypoxic insult happens, they are the ones that will suffer infarction first. We call them, we look at, okay, we don't call them, it's all of them that are called the watershed area. So we look at them individually. The place where you see the watershed infarct includes the brain and the colon. We'll talk about it too. What are these organs that can suffer this infarction? First, the brain, the heart, the kidneys, the liver, and the colon. But it's some specific portion of these organs. Now, the concept of watershed areas are some specific border zones in the body or in an organ that are only supplied by the distal branches of two major arteries without any collateral supply. Let us look at I think I have one image here I was able to get online just to help us understand the you know. So although it's not too clear, we just have to be able to imagine it. So the ACA will be running this way. Mhm. The PCA will be running this way. This is the MCA in the middle. This is the MCA in the middle. So this is the ACA, the anterior cerebral artery. This is the posterior cerebral artery. This is the middle cerebral artery. Now, the watershed areas are areas that are supplied by the distal arteries of two major arteries. Now, that means that we can say that this portion here is a watershed area, this area here, because this is the distal part of the MCA, this is the distal part of the ACA. This is another watershed area. Distal part of the MCA, distal part of the PCA. So we can say that the watershed areas are border zones of the area between the ACA and the MCA and the MCA and the PCA, just like we are seeing here. Now, these areas are going to be, these areas don't have collateral. There's no connection between this place and this place. There's no connection between this place and this place. If there is an ischemic occlusion of okay, no, let me keep that. Let me keep that. So the clinical significance of this is that these areas are going to be the first area that will suffer ischemic or infarctive damage whenever there is hypoperfusion for any reason, because they are supplied by the distal branches of the artery. So we should just try to picture, when there's hypoperfusion, it will take time for blood to get to the most distal. So that means that is the one that will get, deprived of blood first, because, that is the most distal vessel. I don't know if you guys understand that logic.
Yes.
The most distal, that's the one that, of course, relatively contains the little amount of blood. When there's hypoperfusion, is the most distal that will suffer first before the proximal. Is that it gets worse, that it will now start coming to the proximal. But the distal ones, they are going to suffer it first. So that is why these areas are the area that the infarct will settle in first, because they are supplied by the distal branches. The distal branches. So here, distal, here, distal. Because it will take time for blood to get to that area, to take time. So that is one, the watershed area of the brain. The boundary between ACA and MCA and MCA and PCA, watershed. Another example is a heart, but this heart one is not working by the principle of watershed. The part of the heart that suffers ischemic or infarctive damage first is the subendocardium of the left ventricle. Why? The reason is that the right ventricle and the other portion of the left ventricle, some other portion of the left ventricle, predominantly get their blood during diastole and systole. So when the heart is contracting, it's still getting, the coronary arteries are still getting some little blood to supply the major areas like the epicardium, the myocardium. And during diastole too, the heart is relaxing, it's filling with blood. There's going to be blood supply to everywhere. But the endocardium only gets its own blood supply during diastole. It doesn't get in systole because the vessels within the subendocardium, they have very low capacitance. Like the pressure there is not too much, so they can easily get compressed. So when the heart is contracting, the vessels within the subendocardium will be compressed. So blood will not be able to flow to them. They can only fill with blood when the heart is relaxed in diastole. So that means that the volume of blood that is getting to the subendothelium area is even small compared to the one that is getting to the myocardium and the pericardium. So it is logical to say that whenever there is ischemia or hypoxia or infarction, the area that is going to be first affected, that is most vulnerable, would be the subendocardial area. Because little blood is getting to it, because it only gets its own blood during diastolic phase. Do we get that? Do we understand that?
Yes.
All right. The next one is the kidney. Now, the portion of the kidney that suffers ischemic injury first, or that is most vulnerable, is a straight segment of the proximal tubule and a thick ascending limb, the portion of these guys that is embedded in the medulla. Now, the kidneys is divided into two regions, the cortex and the medulla. Initially, the amount of blood in the medulla and the oxygen content in that blood is lesser than the cortex. That one is established already. But we have proximal tubu that is within the medulla. We have thick ascending that's within the medulla. We have um, thin ascending that's within the medulla. We have the collecting duct that's within the medulla. But why is it the straight segment of the proximal tubu and the thick ascending limb that is in the medulla? The reason is because these guys are highly metabolizing. Sorry, they are undergoing a lot of metabolic process. They are consuming a lot of ATP because these guys are the segment that absorb majority of the sodium and the other electrolytes in the kidneys. You guys remember that like 60 or 70% of sodium is absorbed in the PCT, while the next percentage, which is like maybe like 30 to 40, is taken by the thick ascending, and they require energy, ATP, to do that. Hello?
Yes, we're with you.
Exactly. So it means that their own metabolic demand is higher than the other regions of the nephron. So that is why they are the ones that are most vulnerable to hypoxic or ischemic insult. And particularly not their cortical segment, but their medullary segment. Because in the medulla, the oxygen concentration in the medulla is relatively low compared to the cortex. So do you understand that? The straight segment of the proximal tubu and the thick ascending limb, those are the areas that absorb most sodium and chloride and the other electrolytes. Now the next one is the liver. Oh, I'm not sure I have an image for this. Let's try to see if we can bring that out so that we can see what we are talking about. So we look at the functional unit of the liver. Let me just say central lobular area of the liver. So let us see. Yeah. So this is it. Now, this structure is the histology of the hepatocyte, what they look like. Now, all this stuff that you are seeing, this brown one, those are the hepatocytes. At the periphery of the hepatocyte, you have the portal triad that contains the bile duct, the hepatic artery, and the hepatic portal vein. The bile duct, the hepatic artery, and the hepatic portal vein. So the red one that you are seeing outward. So look at the one that is exterior, the most outward. The red one is the hepatic vein, the blue one is the hepatic portal vein, and the green one is the bile duct. This one in the central is the central vein that takes blood away from the liver. Now, it is reasonable to say that if there's going to be ischemia, it is the one that is more farther away from the artery, which includes the hepatic artery and the hepatic portal vein. You guys remember that that is what is taking blood to the liver. Please, don't be deceived. The hepatic portal vein actually supplies blood to the liver, although it's a vein, but it supplies nutrient and blood to the liver because it's a joining of the splenic vein and the supramesenteric vein. So, it contains a lot of nutrients. Though the oxygen content is not as high as that of the hepatic artery, but it still supplies nutrient to the liver, which is very good for the liver. You must not have obstruction of the hepatic portal vein. Now, it means that those hepatocytes that are outwards, that are periportal, that are surrounding the portal tract, those ones will be getting the highest amount of oxygenated blood from the hepatic artery. Why is the one that are closer to the hepatic vein will not? Can you guys picture what we are saying?
Yes.
So the ones that are very close to the central vein, those hepatocytes, we call them the centrilobular area, the centrilobular hepatocyte. They are close to the central vein. The ones that are close to this outward area, this periportal area, we call them the periportal hepatocytes. So those ones are very close to the hepatic artery and the hepatic portal vein. So they'll be getting nutrient, they'll be getting blood, they'll be getting oxygen. But the ones, it will take time for the oxygen to be diffusing to the one that is close to the central vein. So the centrolobular hepatocyte are the ones that will suffer ischemic injury first. Centrolobular necrosis. So let's go back to our. So that's why we are saying.
Sorry, Dr. Babale. Sorry, you said the centrilobular ones are which ones? The ones which are more inward, the
Yeah,
innermost one.
exactly. The one that are more inward. You can see these ones that are surrounding this central vein. Those are the centrolobular ones. So those ones are the ones that will die first. You know,
Okay.
because they are very far away from the hepatic artery. They are very far. But the periportal one, they are
They are close. Okay.
they are close. The last one is the colon. So this colon too is like this watershed of a thing. So I think I have something here. We have 2 points, watershed points in the colon. You have one at the splenic flexure. Splenic flexure is just where you have the transverse colon descending as a descending colon. So where it's bending very close to the spleen as the descending colon, that is the splenic flexure. That is one watershed point. The other watershed point is at the retrosigmoid junction, the junction between the sigmoid and the rectum, where the sigmoid continues as the rectum. So don't forget the splenic flexure and the rectosigmoid junction. You don't actually need to remember these names. Splenic flexure is known as Gibbs point, but Sudeck point is known as. The way I remember, if I want to remember it, I just say, okay, I know that I have to alternate it. Splenic flexure is one that starts with S. So S is for the other one. So retrosigmoid will be the one that's starting with the S. That's the Sudeck. While splenic flexure is the Gibbs point, but nobody will ask us those names. The vessel, because we've said that watershed areas are areas of the organs that are supplied by the distal artery of two major vessels, distal branches of two major vessels without any collateral connection. There's no collateral vascularity. Now, looking at the splenic flexure, what are the two vessels that we are talking about there? We're actually looking at the connection between the superior mesenteric artery and the inferior mesenteric artery. The distal part of the superior mesenteric artery that is providing the blood supply is the middle colic artery. The distal part of the inferior mesenteric artery that is providing the blood supply to the splenic area is the left colic artery. That is what is forming that connection at the splenic flexure. For the rectosigmoid, the connection is between the last sigmoid branch of the inferior mesenteric artery. This rectosigmoid area is actually from the inferior mesenteric artery. The large sigmoid branch of the retrosigmoid artery that we call the sigmoid emal artery, and that is one that's supplying the sigmoid, and the superior rectal artery, which is also the last branch of the inferior mesenteric artery. So both of them together form a connection that supplies this retrosigmoid junction. So if there's
Dr.
anything,
Babale,
yeah,
left for the splenic flexure, left colic and which one?
left colic and middle colic. Middle colic is coming from SMA. Left colic is coming from IMA. Yeah. So there's no collateral connection between those guys, and they are the most distal portion of those two arteries that we have talked about. They are the most distal. The middle colic, is part of the most distal for the SMA. The left colic is part of the most distal for the IMA. At the retrosigmoid too, part of the most distal for the IMA is the sigmoid emal and the superior rectal. So it means that once there is ischemia from anything, those last branches will not take blood. They will take blood last, and they will be the one to suffer ischemia first. And they are even the most vulnerable, because it's even possible that blood will not eventually reach those distal area. It will not reach there. So, um, so there are some neurons that are particularly vulnerable to this hypoxic ischemic insult. So actually, I just don't want to go through the process of explaining. I think we just need to palm it to guys, because the process is actually somewhat long. But okay, so because I don't want us to palm, the reason is that let's list those areas first. the Purkinje cells of the cerebellum, the pyramidal cells of the hippocampus, and the neocortex. So the neocortex is arranged in some layers. So the neocortex of the brain, that's the cortex of the brain properly, you know, the layer 3, 5, 6, those are the layers that are, highly vulnerable to hypoxic ischemic insult. The Purkinje cells of the cerebellum, the pyramidal cells of the hippocampus, especially the CA1 region, and the 3, 5, 6 layer of the neocortex. These guys have the highest level of glutamate. So when there is ischemic injury from anything, we are going to see questions on that. I don't have the questions here, but I'm still going to show us. So part of the thing that happens following ischemic injury to the brain, with respect to the changes in the electrolyte or the neurotransmitter, is after the paralysis of the sodium potassium ATPase pump and sodium is accumulating in the cell and there's cellular edema and all those things, there's going to be increased release of um, glutamate and aspartate, but predominantly glutamate from the neurons into the synaptic cleft. Glutamate will activate what we call the NMDA receptors. NMDA receptors are glutamate receptors. Once they are activated, they release calcium. Calcium will now start driving the process by which those guys will die. So you guys remember that once intracellular calcium increases, start activating intracellular proteins and all those things that will kill off those cells. Do you guys get that? So the reason why these guys are now the most susceptible is because they have the highest, one of the explanations
Glutamate level.
is that they have the highest level of glutamate. Oh, I'm happy we're able to make that very short. So don't forget that Purkinje cells of the cerebellum, the pyramidal cells of the hippocampus, and the neocortex of the brain. So in case you see it in a question, they can ask this. They ask this a lot. In fact, they just tell you somebody suffers hypovolemic shock suddenly. Which organ do you think will suffer ischemic insult first? They'll put hippocampus there. They'll put spleen. They'll put they'll put they can put heart. Okay, no, they can put myocardium of the heart. They can put so many things. So you already know what you are looking for. Those any of these guys. So
Hippocampus.
just pick your hippocampus or your cerebellum or the neocortex. That is
Or
it.
the neocortex.
Yeah. So let us look at the infarct. Let's look at the infarct and how they uh, what are the types. So infarct is just when you have necrosis of the tissue due to hypoperfusion. That is it. So necrosis can follow so many things. If we have fatty necrosis of an area, we will not say that area is infarcted. No. Infarct is only coming from death of a tissue due to hypoperfusion, due to like coagulative necrosis. Infarct. That is why if you go back to the definition for coagulative necrosis, they said it is seen in ischemia and infarct in most tissues except the brain. So now let's look at those infarct one by one. We have two types, the red and the pale infarct. It's very easy to remember. You classify it into the red or the pale based on the amount of blood that is in that infarct. That is the code. Once you remember that, you have palmed it. You classify it based on the amount of blood that is in that infarct. Okay, this guy has undergone infarct. He's already infarcted. It is dead. But does it look red because it has blood? Oh, there's blood there. It's looking reddish like image A. That is the red infarct. Does it look white like as if there's no blood flow at all? That is a pale infarct. Now, what are the causes of red infarct? What are the causes of pale infarct? Causes of red infarct include tissues that have dual supply. Now, this one is very straightforward, very easy to palm. Just imagine that there's occlusion of one. Let's take the liver, for example. There's occlusion of, we said the liver is supplied by two things, hepatic portal vein and the hepatic artery. Both of them are supplying the liver. Let's say there's occlusion of the hepatic portal vein, and the hepatic portal vein is going to cause infarct on some particular areas of the liver. You know that the hepatic artery is still patent. So that means that the hepatic artery will continue to deliver blood to the liver. And those blood that is traveling to the liver from the hepatic artery will fill those infected areas from the hepatic portal vein, and it will appear red. Do we understand the analogy?
Yeah,
That's it.
because the hepatic portal vein and the hepatic artery are kind of like supplying the same area. So if there's like an occlusion of the portal vein, the artery will still perfuse that area.
Exactly.
So, but
Exactly.
one will wonder then, why was there and what's it called, ischemia if the artery was still
No,
perfusing.
it's not. That's why you made the statement. You said the same area. It's actually different areas. You know, arteries will
Okay.
go to, this one will go to supply its own. That one will go to supply its own. You understand? But they are all supplying the organ collectively. You get? Do you
Okay.
understand, Dr. Zulia? So that's the way to look at it. Hello?
Yes, I'm getting.
So that's, that if you look at the gross image of something, you see that arteries, they are lying, they travel, the kind of vessels run on tissues, they run. So this one will run on some particular aspect of the tissue. That one too will run on some particular aspect of the tissue. So you cannot have two
Mm,
arteries lying on one tissue. Do you get what I'm saying?
okay.
Yeah,
Okay.
picture it that way. Picture it that way. So the branches from the hepatic portal vein, they will supply their own. Now, if there's obstruction of the hepatic portal vein, those areas will be infected. The
Okay.
hepatic artery is still patent, so it will now continue to deliver blood. The blood will now flow around those infected. That's why you are seeing red blood surrounding this dark area. So you see this dark area, the infected area. You can see the red area like filling in those infected area. You can see. Can you
Mm-hmm.
appreciate that? So that is that
Mm-hmm.
is the that is the red infarct. So all organs that's having multiple blood supply, they will undergo red infarct. Now let's take them one by one. The liver, we have said that hepatic artery and hepatic portal vein. The lungs. Now, many people make mistake of thinking we have two hepatic pulmonary artery. No. If you have occlusion of one pulmonary artery, it is gone. It is not another pulmonary artery that is making it have red infarct. It's actually due to another vessel that we call the brocal artery. There's the brocal artery that's also there, that's coming from the thoracic aorta. They also supply the lung in addition to the pulmonary artery. So if you have a pulmonary embolism, occluding blood flow to the lungs, blood supply will now continue through the pulmonary artery to the lungs, and you have the red infarct. For the intestine, this one is very straightforward. SMA, IMA, SMA, IMA, SMA, IMA. Both of them will take care of that. Testes is supplied by three arteries. Testicular artery is the major. There is artery to the cremasteric artery, there's cremasteric artery and artery to the vas deferens. So the artery to the vas deferens, the testicular artery, and the cremasteric artery all supply the testes. So that is why the liver, the lungs, the intestine, and the testes can suffer red infarct. What is another cause of red infarct? Reperfusion. So this one is very self-explanatory. Just imagine that there's an occlusion of the heart. There's occlusion of the coronary artery to the heart. So, you know, when that occlusion happened, there's already an infarct. It's there. We now come in, we do percutaneous coronary intervention, and we open up that vessel, or we do angioplasty. We open up that vessel and we reestablish blood flow. You know that it means that blood is going to find its way to the infarcted area, and there's going to be what? Red infarct. But it will cause something we call reperfusion injury. Now, guys, the way we can understand reperfusion injury without stress is just to assume that reperfusion injury is due to free radicals. Now that one is established concept. Reperfusion injury is due to free radicals. So reperfusion injury can be a bad event and reperfusion rather can be a bad event and can be good. Okay, it will help you restore blood flow, fine, but it can also further cause insults to the tissue because it generates free radical. How? Any tissue that is already infected, the mitochondrion there will be dysfunctional. We've talked about mitochondrial changes in irreversible and reversible cell injury. They are dysfunctional. And if you guys remember, in oxidative phosphorylation, we transfer electron to oxygen so that we can reduce it to water. Do you guys remember that? We transfer electron to oxygen. Then
Yeah.
we had two
The
molecules of
electron
hydrogen
transport chain.
through the electron transport chain. Thank you, Dr. Zilia. Now, in mitochondria that are dysfunctional, that reduction of the oxygen is not complete, and they will generate free radicals in the process. Instead of you now reducing your oxygen O2 to H2O, you will now be reducing it to OH minus. Sorry, it's not OH minus, it's actually OH dot. That dot is representing a free electron. Free radicals are molecules that contain a free electron in the outer orbit. So instead of you reducing your oxygen by transferring electron to it completely to hydrogen, because the mitochondria they cannot do their work very well, they will now be transferring electron incompletely to the oxygen and they'll be reducing it to free radicals like hydroxyl radicals. Now, mind you, we are going to talk about free radical next. Oxidative phosphorylation is not a perfect process. It will still generate some little amount of hydroxyl free radicals. It will generate some little amount of superoxide radicals. But there are some mechanisms that are set aside to help us take care of those guys. There are some scavenging enzymes that are there to help us remove, those free radicals. Now that is what they are saying here. Reperfusion will cause red infarct, but it can also worsen the damage by causing free radical generation, which can attack those tissue again and bring about lipid peroxidization. You guys remember that we're always talking about lipid peroxidization. That is addition of free radicals to the phospholipid within the membrane. It will damage the membrane. So don't forget, whenever you see reperfusion injury, what you are scared of is actually free radicals. Because when you open up, you are establishing the oxygen flow again. And the mitochondria will be receiving oxygen, but they will not use the oxygen well. They will now be incompletely transferring the electron to that oxygen to generate free radicals like superoxide or hydroxyl radical. So it's better for you not to even open it up. Allow it die. Now for you to open it up, allow establishment of continuous blood flow that is delivering more oxygen, but they are not using the mitochondria are not using the oxygen well. Instead of using it well, they are using it to generate free radical that is further causing damage to the tissue. Do we understand the process now?
Yeah.
So once you want to remember the cause of red infarct, just think about something that is doubly supplied with blood, maybe 2 or 3 vessels, or reperfusion. Something is already infected, you open it up again, restore blood flow. That is red infarct already. Blood will now surround those infected areas, and you have your red infarct. So with
How are they
reperfusion,
generating the free radicals again? Sorry.
From the reperfusion, the blood supply is under the fact that the tissue is already necrosed, the mitochondria, there's already a mitochondrial damage. And so that means the oxygen that is coming in cannot be converted to water. So there's formation of free radicals from the oxygen that is coming in from the blood perfusion. And so that's the free radical that is generated is the one that is now going to further damage the tissue.
yeah.
Is that it, Doctor?
Thank you very much, Dr.
All right.
Zia. Yeah. So the infarct has already caused damage to the mitochondria. They cannot completely reduce oxygen to water, because they are going to incompletely transfer electron to that oxygen that is coming in from the reperfusion. So in the process, they are going to be generating free radicals. That is it. Do you get it, Dr. Lushala?
Yeah, sure.
So pale infarct occurs in solid organs with single arterial supply. That one is, very clear. Single artery like the coronary artery, one coronary artery, right or left. If you have right coronary artery occluded, problem. Left coronary occluded, or the kidneys, just the renal artery. There's no bilateral. The renal arteries are bilateral, but they are for individual organs. This one is for that one is for the other one. So those ones don't have any source for blood flow to come in again. So they will suffer pale infarct. So single organs like the heart and the kidney suffer pale infarct. Okay. Let's talk about free radical. We cannot talk about this free radical. It will take time. We'll continue from there in the
Yeah, I
continue
don't
from there in the
understand.
future. So do you have any question? I think this lecture should be,
Mm-hmm.
do you
I think
guys
I have a question.
okay, okay.
But the question is from like the yesterday distance because when we were talking about it, you talked about laddering, DNA
Yes, laddering.
laddering
Mm-hmm.
something.
Mm-hmm.
I think I didn't really understand the concept of laddering. And here they said it's a sensitive indicator for apoptosis.
Apoptosis, yeah.
But
So
you said that pyknosis is the sensitive indicator. So I'm wondering
no,
okay, did I
Dr.
mix it
Julia.
up?
there are so many things that can be indicator for something. You know,
Okay.
just as DNA labeling is important, pekinosis is also important. Shey you get.
Okay.
So pekinosis, the DNA labeling just means that when the caspase are activated, they will activate some enzyme that we call endonuclease. Endonuclease are enzymes that cleaves DNA. Now you know that DNA we weigh DNA in terms of base pair. That's the way we weigh DNA. If you want to say that a DNA is big, you describe it in terms of the base pair that it contains. Does it contain 1 million base pair or 500 base pair? You get, Dr. Tia?
Mm-hmm.
Now,
Mm-hmm.
what the
Mm-hmm.
endonuclease will do is to start cleaving the DNA in the multiple of 180 base pair. So if you have a DNA molecule that has 1,000 base pair, it's going to start cleaving from 0 to 180. Cleave that off. It
Okay.
can cleave another
Okay.
180. You get? So they will keep arranging like that. Because what will make those DNA appear to you, the thickness that you are seeing is based on the base pair that you are seeing. So the more the
Mm.
base pair, the darker it will appear on the electrophoresis machine. Do you get it?
Okay.
But now you
Okay.
are doing the sequencing with a machine. It will be giving you the precise value of those DNA fragments. You'll be seeing that,
Mm.
okay, you see one 180, you see another one 360, you see another one 540. You will see that there are multiples of 180.
Okay.
That is telling you that this is apoptosis that is happening. So that's what it
Okay.
is. Yeah.
Okay. And
So
then I also wanted to just say that you said that cariolysis is not seen in what's it called? That is only in necrotic tissue, like the cariolysis part of the
the
what's
nuclear
it called?
dissolution.
Nucleus dissolution is
Okay.
not seen in apoptosis. Is
Mm-hmm.
that I think you said something like that, Abby?
Yeah, yeah. So
Okay.
some texts will tell you that we have so many superior authority. Before I made that statement, I actually did some research. Some texts will tell you that it's there. Some will tell you that it's not there. But me, I want to follow what is in first stage so that I don't give you guys truth. You understand?
Okay.
So since
Okay.
first stage did not mention it, we just assume that it is not
It's
there.
not there.
Exactly.
Okay.
So do you have any other question before we call it a day? Okay. I think we are going to call it a okay, okay, okay. So we are going to continue in the evening by God's grace. All right. So
Thank you, Bokubali.
Thank you
yeah,
very
you're
much.
welcome. Bye bye everybody.
Bye.